Okay, welcome everyone to the webinar today. And our topic today is post-traumatic stress disorder and grief in a K through 8 setting. Our presenter is Don Mitkus from Alexian Brothers, and also a consultant for the Student Assistance Center here at Prevention First. Our next webinar is May 27th, and that's resource mapping for interventions. It'll be our last webinar for this fiscal year. And so if you would like to register for that, you can go to our website and do that, and we'll be happy to have you on our webinar. Want to remind you that during the presentation, you're in listen-only mode. If you do have questions during the webinar, don't hesitate to enter those either into the questions or chat section on the control panel on the right-hand side of your screen, and I will break in and ask those questions for you. And at the end, we'll try to have some time for questions and answers. I know this is a very meaty topic, and Don has a lot of information for us. So without further ado, I'm going to turn it over to Don to start his presentation. Don.
Thank you, Dale. All right, so okay, so thanks, Dale. Again, my name is Don Mitkus, consultant for the Student Assistance Center at Prevention First, and have done a number of webinars. And today our topic is the effects of trauma on children and adolescents. So trauma and grief, which are very highly interconnected, and is certainly getting more and more attention on how trauma is impacting children in the school setting, and how it can look different depending on your setting, and some clues to look for as far as whether or not this is something you might be staring at the face in your office. So, some central questions. Do kids in my school have trauma that isn't being identified, and if so, what can I do? What is a trauma lens, and what does it mean to see a child through a trauma lens? So really what we're here to do today is to give you that trauma lens to be able to view a kid through, because you may come across a situation behaviorally, or a kid dealing with some very aberrant behaviors, and one of the questions that we do want to ask ourselves is, can these things be driven by trauma? Because that can be helpful and informative as far as how we're going to approach that particular student. The picture of the iceberg, of course, is when you're dealing with trauma and grief, often you are just seeing the tip of the iceberg. The other 80 to 90% of what's going on is certainly buried underneath the surface, and that's what we're, in a sense, trying to identify. If there is something lurking under the surface, and if so, what to do. There's a few trauma principles I do want to cover with you. Trauma, like many things that have gotten attention over the years, where we can be all too ready to look at, is it trauma? This is trauma, and that's trauma, and they got a bad test grade, so they were traumatized. If everything's trauma, nothing is trauma. So we'll identify what trauma is and what effect it has. It's the child's experience of the event, not the event itself, that's traumatizing. So we're all too often all too ready to say, you know what, hey, it was not a big deal, and get over it. So you fell and you broke your arm, not a big deal. I did that when I was a kid, not a problem. You may have two very similar events. You might have had an experience yourself that one of your students is experiencing, and for you it might not have been a big deal. But based on a number of factors, it could very well be highly traumatizing to another person. So you can have a dozen people experiencing the exact same thing, and you'll have different levels of traumatic impact on each of those people, because it's their subjective experience that determines the trauma, not the event itself. So if we don't look for acknowledged trauma in the lives of children and adolescents, we end up chasing behaviors and limiting the possibilities for change, because trauma finds a way to express itself, and often it expresses itself in behaviors that are we perceive as maladaptive. We'll talk a little bit about that, but you wind up chasing the behaviors and addressing the behaviors, and there's suspensions and detentions and consequences, yet it's not what's driving. It's not the thing itself. It's just driving these particular behaviors, and that's the thing to get at in order for those behaviors to change. So the behavioral and emotional adaptations that maltreated children or traumatized children make in order to survive are really quite brilliant creative solutions, and often personally costly. But they develop these behaviors and adaptations and ways of interacting with the world in order to cope and survive with, and particularly with repeated exposures to traumatic events. So another principle: since trauma equals chaos, structure and good structure is necessary for healing. And finally, if you don't ask, they won't tell. A lot of the behaviors that are developed are protective in nature, to protect themselves from the trauma, or to protect others from finding out about the trauma as well. I would urge some caution with this, however, and we'll talk a little bit about that. Uncovering trauma is a big deal, and I don't want to understate this. It is a big deal, and often requires some professional assistance of an outside referral to be able to cope with the trauma. So you have to be careful on how you unpackage it or uncover it, because you may find yourself in a situation that's beyond the scope of what you can do in your setting. So traumatic stress is actually common. I mean, more than 1 in 4 American children will experience a serious traumatic event by their 16th birthday. Children with developmental disabilities are much more likely to be abused or neglected and traumatized. And the children at greatest risk for sexual abuse are between the ages of 7 and 13. They're most likely to be victimized during that stage. So 4 out of every 20 girls will be assaulted sexually by the age of 18, and 1 or 2 of every 20 boys. So between 10 and 20%. 5 to 10% of boys are also victims of sexual assault, which we often goes unrecognized. Exposure to community violence is a growing source of trauma for children. There's no end of the media coverage of the increasing violence in our urban areas, particularly Chicago. Madison, which is we think of as in Chicago, think is somewhat of a more rural city, and Wisconsin. There was a survey done of 6th graders, and nearly a third of them reported substantial exposure to violence, and over 10% screened reported both exposure to trauma and clinically significant symptoms of child traumatic stress. And this is in a community that has a lower violence rate than the Chicago metropolitan area does. Foster care. We often find kids in our care that are in foster care situations. Higher rates. It's a 20% higher rate for post-traumatic stress disorder compared with the general population. Their rate is 21% versus a little less than 5% for the general populace. And you compare that with war veterans, PTSD is far more common in alumni of foster care than Vietnam veterans, Afghanistan war and Iraqi war veterans have a much lower rate of PTSD than these kids do. They have a higher rate for major depression, phobias, panic disorders, anxiety, addiction, and bulimia. And there's the study of children in foster care revealing PTSD. 60% of sexually abused children experience post-traumatic stress disorder, and 42% of physically abused children experience symptoms of PTSD. 18% who had not experienced either type of abuse had PTSD, possible as a result to a domestic abuse or domestic or community violence. So 1 out of 3 children entering foster care age 6 to 8 meet the criteria for PTSD, which I find to be quite remarkable, that this is a very vulnerable population. Child traumatic stress is serious and interferes with their ability to concentrate and learn, can delay development of their brains and bodies, leads to depression, substance use, health problems, school failure, delinquency, and future employment problems are all potential outcomes of experiencing traumatic stress as a child. It changes how they view the world, how they view their future self, their influences their behavior, their interests, and certainly impacts their ability to develop and maintain relationship with friends socially, as well as relationships with family. It takes a huge toll on families and communities. Certainly educational impact is significant, with learning problems, lower GPA, more absences, more negative comments in their permanent record of a disciplinary nature. And of course, with these sorts of behaviors, there's a number of students that experience run-ins with the police, with the juvenile justice and criminal system. So, of course, they're at increased risk because of aberrant behaviors that are adaptive for some reason for the trauma, put them at great risk for arrest, for committing violent crime, perpetrating domestic violence, or drug use, which we know is a common reason for incarceration. So, recognizing the victimization as this is said by Julian Ford back in 2005, potential source of abusive behavior doesn't excuse the behavior. We're not looking for a reason or using trauma as a defense for antisocial or aberrant behavior, but what we are looking at it as is a reason to do more prevention or to treat it more effectively when it is recognized, so they don't continue this cycle of maladaptive behaviors. Some of the health impacts: smoking, STDs, sexually acting out, we'll talk a little bit about that, substance use, IV drug use, heart disease, obesity, unintended pregnancy, and avoidance of preventative care, which is important. That when you go to a doctor, doctors ask questions, and those that have suffered trauma don't want questions asked, so they are not necessarily fond of going to physicians. There was a study done on the adverse childhood experience, the ACE study, adverse childhood experiences. It was done by Kaiser Permanente out in California in conjunction with the Centers for the CDC. So Kaiser Permanente is just, it basically controls healthcare in California. So they have a large number of members that they can gather information on. So they looked at 18,000 HMO members, which is a pretty big sample size. What they were able to identify were 9 categories of adverse childhood experiences. And the total number of categories where they score, each category, if there's a yes there, counts as a point. And total that up, and that's their adverse childhood experiences score. So the 9 categories are growing up in a household under the age of 18 where there's recurrent physical abuse, recurrent emotional abuse, emotional or physical neglect, sexual abuse, if the mother is being treated violently, if there's an alcohol or drug abuser in the house, one member of the household is incarcerated, a member of the household that's chronically depressed, suicidal, chronically mentally ill, or if they're absent, 1 or 2 absent parents. these are all these are the 9 categories of adverse childhood experiences that are indicative of trauma. So this powerful relationship between our emotional experiences as children and our physical and mental well-being as an adult is quite remarkable. So with the ACE, someone with an ACE score of 4 or more is 4.5 more times likely to be suffering from depression than someone that has not had any of those experiences. Of an ACE score of 4 is tremendously impacts the likelihood of attempting suicide. And the higher the scores, the more likely someone is to have a suicide attempt. And then in men, in particular, an ACE score of 6 is a strong, very, very strong indicator of IV drug use or serious substance dependency. The higher the ACE score, the more likely that someone is to suffer from heart disease, diabetes, obesity, unintended pregnancy, STDs, alcoholism. Again, childhood traumatic stress has long-lasting impact even after the stressor or the event or the trigger has been removed, or they moved away from that traumatic environment. So again, trauma is under-recognized. If we look at the data, and this is 98. This is almost 20 years ago, and there's certainly been a lot more research into the identification of trauma in that time. There was nearly 10% reported sexual assault, 17% physical assault, nearly 40% witnessing violence, and then another study that was 20 years ago bears that out as well. Only 1 in 4 have witnessed or not experienced direct violence themselves. In 2003, the U.S. Department of Justice stated that the rates of interpersonal violence and victimization of 17-year-olds is extremely high, and witnessing violence is common. Again, we see this on a near daily basis on the news as far as the shootings and the violence in our city. And then 70% of adolescents have been exposed to violence versus 4 out of 10 adults. So the rate of exposure to violence and traumatic events is getting higher over time.
Don, you mentioned the media reports of violence and those kinds of things. I want to back that up because personally, I think about the 9/11 attacks and kind of the secondary trauma that young people experience through that. And that happened with my own daughter, who was a baby when 9/11 happened. And when she was about 8, she started not wanting to sleep in her upstairs bedroom, and which was unusual. And when I asked her why, she told me she was afraid that a plane was going to fly into the house. And so it was something that, even though she hadn't experienced it kind of firsthand, secondarily through the media and through us watching it, she was impacted by that.
Right. So even these secondary, strong event, even witnessing it via media. Certainly, violence in urban settings is nothing new, but our coverage of it and exposure to it, and repeated coverage of it, the concept of 24-hour news is something that's only about 30 years old. So our children have grown up with repeated and constant exposure through the media to violence in their communities, especially if they're reporting on violence in their own communities. So what do the kids learn from the trauma? The negatives, they expect traumatic events of the world. They expect these things to happen. They expect that bad things to happen to them and that no one can protect them. They don't expect that the law or the police are able to protect them. Certainly the happenings in Ferguson and in Boston that have been getting so much coverage are indicators that the lack of faith in our protectors is severely diminished, and they learn to be helpless. It's learned helplessness. That's what trauma teaches: is that no matter what you do, these things are still going to happen. So why even try? Calvin and Hobbes. It's I always put my duck in first. Why? Because you like the duck? No, I'm looking for sharks. So there's our children who are being victimized learn how to adapt in not always adaptive way, what we would consider adaptive ways. What positives do they learn from trauma? How to conduct themselves in the midst of danger, especially those that are in who have witnessed violence in their communities, that they're more protective and more wary. For those that are being repeatedly traumatized in the home, learning ways to protect themselves or avoid the abuser. They can learn if there's intervention that there are others that can protect and rescue them. That there is support available after a trauma if there's intervention. And these folks often on the far side, for those that get help, that get treatment, that resolve the trauma, tend to come out of it with increased compassion and understanding of what others go through, because they've been there themselves. And often their experiences allow them to put themselves in someone else's shoes in a way that is that others are not able to. So traumatic stress, we've talked a lot about this, but traumatic stress is just defined as the response to events that can cause death, loss, serious injury, or threat to a child's well-being or the well-being of someone close to the child. Again, going back to the trauma principles, if everything's trauma, nothing is trauma. This defines what trauma is that there's a perceived threat to their bodily, physical integrity, or to the physical integrity of someone close to them, such as a parent. Traumatic stress causes the primal fight or flight or freeze response. It involves terror, helplessness, horror. It results in physical sensations when the fight or flight or freeze response is triggered. Often that comes with a strong adrenal response, which will cause rapid heart rate, trembling, sense of being in slow motion. Time slows down, which only serves to lengthen perceptually the traumatic event. Not every event that's distressing necessarily results in traumatic stress. And again, just to reiterate what we said before, if an event, 6 people can experience an event, and one of them might experience traumatic stress from it, the other 5 might be just fine. But it's our perception of that event which results in the traumatic or the trauma that people suffer from. Even back in ancient Rome, we recognize this fact that the thing that upsets people is not what happened, but what they think it means. So we just saw something, a Philadelphia train derailment, where dozens of people were injured, and out of that, there will certainly be a percentage that experienced traumatic stress. Some may just walk away and go, "Wow, whew, thank goodness I got out of that. That was harrowing." And some people that might experience symptoms of traumatic stress or acute stress disorder, or even turning into a post-traumatic stress disorder because of how they perceive it. So the subjective characteristics of trauma is their appraisal of the event. Was it uncontrollable or malicious? Did they have control over the situation? Were they maliciously the victim of the traumatic stress? of their appraisal of their action. Was it ineffective or effective? What the action they took when the traumatic event occurred, were they, in looking back on it, were they, did they feel like they did what they could? What they did, was it effective in preventing further harm? That the feeling of ineffectiveness or helplessness can often create more traumatic stress. And then their appraisal of themselves, helpless and shameful, or brave and capable. How did they comport themselves during the traumatic event? Or how did they perceive that they comported themselves? And then the appraisal of others, impotent or dangerous versus safe and protective. During the traumatic event, how did others comport themselves? All of these factors are subjectively viewed by that individual and will determine whether or not the event that occurs results in traumatic stress. So some other factors that we call them traumatogenic factors that increase or decrease the likelihood of an event potentially causing traumatic stress. Age. Certainly, the younger the younger person is at the event, the more likely it is to be traumatic. Was it relational versus non-relational? Was the traumatic event perpetrated by someone that was close to that person? What was the relationship between the victim and the perpetrator? Was it a stranger assault, or was it a familial assault? How frequent, how long, and how severe was the traumatic event? This has significant impact on a number of factors, which we'll cover in a few minutes. But the severity, duration, and frequency of the traumatic event has a significant impact on how likely it is to be traumatic. Was it a single episode, or was it repeated? Protection. Was there someone or some factor that could have been protective but was or was not? What was the response of their caregiver at the time, especially in childhood? If they were victim of traumatic events, how did their caregivers respond to that traumatic event? Responsibility and blame. How much did they take responsibility for the traumatic event? How much do they feel responsible for it occurring? And then what was the response of those around them, of the community outside the home, or the societal response if that traumatic event was public or known outside of their household? Some other risk factors, if there's poor, anxious, or disrupted attachment to a caregiver, to a parent, if there's prior trauma, if they already suffer from an anxiety or depressive disorder, in particular postpartum or peripartum depression. Are there neurological issues? Is there developmental disability? As we covered before, those with developmental disabilities are far more vulnerable to trauma than those without. Were they prematurely born? Is there a caregiver that is suffering from their own active trauma symptoms? Was a trauma experienced by the whole family, and their caregiver is responding to their own traumatic stress in a way that now the child sees? And as we know, we learn most of our ways of coping with things initially from our parents or from our caregivers. So seeing how they're responding to the event can impact whether or not they experience traumatic stress as well. Caregivers with alcohol or drug issues, their own alcohol or drug issues can impact whether or not they experience traumatic stress. Poverty. So if they have poverty, meaning that their access to care or intervention is much less than those that are not at a poverty level. So that's also a risk factor.
Don, I'd like to throw in here, I think a lot of those risk factors are things that we see a lot of in children who are in the foster care system, especially that poor, anxious, or disrupted attachment, the poverty issues, and some of the issues in terms of active trauma symptoms and AODA use I think certainly has an impact on kids in the foster care system.
Absolutely. And as we saw before, the percentage of those in foster care that experience traumatic stress is much higher, much more likely to be evidence than those that are in even a single parent household, which is also a risk factor, but certainly much more than in a two-parent household or intact household. So again, protective factors: secure attachment to a caregiver. If the caregiver also suffered from trauma, that they have resolved their trauma issues and are practicing good self-care. The two-parent family, that when the traumatized child is acting their trauma out, the benefit of a two-parent family is that they can relieve each other, so to speak, and at least one is able to give full attention at any given time. The resiliency factor and temperament, just how they're built, can determine, it can be a protective factor. So we know that some kids are just naturally, from a temperament and personality perspective, more resilient to injury or hurts than others. Intelligence or neurological resources, again, not suffering from cognitive delays or developmental disabilities. There's a protective adult, a shielding adult that can protect them from further trauma. That there's no blame placed on the child for the traumatic event, which goes, feeds into if there's any indication or inference that the child was complicit or contributed to the traumatic event, can certainly be a huge contributing factor to the development of to traumatic stress and PTSD and acute stress disorder. A parental response that's affirming and protective post event. The caregiver's ability to tolerate the child's reactions. Again, trauma finds a way to express itself, and it's often in ways that are not pro-social or not socially acceptable, and how tolerant is that caregiver to those reactions and understanding that where those reactions are emanating from. And also spirituality, meaning connection to a higher power of some sort, and the comfort of a spiritual community can be very protective in the face of an event that's potentially traumatic. So diagnosis. There's a difference between acute stress disorder and post-traumatic stress disorder. Acute stress disorder will manifest after a potentially traumatic event within a couple of days, but it's brief. It's typically for a few weeks. There's decrease in functionality, some symptoms we'll talk about, but it's short-lived. Acute stress disorder symptoms that persist for more than a month after the event can then qualify for a diagnosis of post-traumatic stress disorder. So some of the symptoms that we experience with both, these are symptoms that if they're less than a month old is acute stress disorder, which is normal after a potentially perceived traumatic event. But lasts more than a month, it can persist for quite a long time if unaddressed. Includes re-experiencing, so they might have nightmares. They might see danger when there's not danger. That they have recurrent memories, often at unwanted times. Body memories, meaning that they physically experience the symptoms that they were experiencing during the traumatic event, coming unbidden. Avoidance, they can, especially in particular with those that are who have been repeatedly traumatized, they can often dissociate, meaning they numb out. Cognitively they go somewhere else to detach from the traumatic stress. They isolate. There's little interest in activities normal for someone their age. if they don't engage, they can't get hurt. And if they're getting hurt, they can go somewhere else to not experience that pain. They can experience increased arousal, be anxious, they can be hypervigilant, irritable, quick to anger. They have a very low threshold for startle response. They have difficulty falling asleep and staying asleep, often suffer from physical or somatic complaints. And the limits of the problem with, and there are problems when talking about children and post-traumatic stress, is that this was, PTSD was conceptualized out of working with veterans. The Diagnostic and Statistical Manual is the book that codifies all of our diagnoses, and the PTSD diagnosis came along with DSM-3, which was around the time when there was greater awareness of PTSD in our veterans from Vietnam, and putting a name to something and identifying for what it was so it can then be treated. So it was between the Vietnam vets, and also there was a marked resemblance between the symptoms that veterans experience that were being experienced by victims of rape as adults. And the PTSD focuses on single event traumas. So it could sexual assaults, a bad happening on the battlefield. That's what the PTSD diagnosis was conceptualized around, were these single event traumas, and as adults. With the greater understanding of trauma and how it impacts not only adults but children, we've come up with some new terminology, complex trauma, and the brain. So complex trauma is a more accurate description of what we may be seeing in our kids, especially those that are being repeatedly traumatized or exposed to traumatic events. So chronic trauma interferes with neurobiological development and the capacity to integrate sensory, emotional, and cognitive information into a cohesive whole. So what Ford is saying here is that repeated trauma actually impacts how the brain develops in children, because that's what's happening throughout childhood into adolescence, is the brain is developing. And traumas during that time of development can create some long-lasting issues for an individual versus an individual that experiences trauma as an adult. So prolonged chronic trauma leads to things such as dysregulated emotions, rage, fear, betrayal, resignation, defeat, shame. These are these folks have a hard time regulating how they feel, especially in dealing with strong emotions becomes especially problematic, and they develop other ways to deal with it. So the efforts to ward off these emotions coming unbidden include things like substance abuse and self-injury, disassociation, and another way that they come to cope with it is to reenact the trauma with others. In feeling helpless, they may do things that allow them to relive the trauma, hoping to rewrite the script at some level. And what that winds up doing, reenactment simply, although it provides temporary relief of the traumatic stress, winds up re-traumatizing and continuing that traumatic pattern. So reenactment is recreating the trauma in new situations, often with new people, through tension-reducing behavior. So some examples: after a serious car accident, a teen might begin to drive recklessly. After being sexually assaulted, and it's not uncommon for someone to sexually act out and be hypersexual, or being physically abused to get into physical altercations with others. These maladaptive behaviors are ways of tension reduction on the short term. It provides some sort of relief because they're, again, attempting to rewrite the script. But again, as we know, these attempts are often are failures that will re-traumatize and continually traumatize the victim and keep them in that cycle. They create reenactment also recreates old relationships with new people. It tests the negative internal working model for proof that it's right, that it reinforces these feelings that they're experiencing, the feelings of worthlessness, feeling they're unsafe, that they're ineffective, that others, caregivers, are unreliable and unresponsive, unsafe, and ultimately will reject them. These feelings of shame and guilt and worthlessness that are a result of the traumatic stress are proven again through reenactment of the traumatic event. It vents frustration and anger. It mitigates the building anxiety, contributes to sabotage of caregivers to aid their loved ones. It pushes them away, which is another way. If there's, if the caregiver is viewed as ineffective, well, if I keep doing this, it's just going to keep proving that they're ineffective and not able to keep me safe, because I'm not worth keeping safe. So the negative working model starts with reenactment. The response of the caregiver, which is the reenactment, is meant to push them away or cause them to reject the victim, which feeds into the negative working model of helplessness and worthlessness, which results in more conduct problems following reenactment, and the cycle continues. So a common caregiver response during these reenactments or these acting outs are urges to reject the child, abusive impulses towards the child, emotional withdrawal and depression, feelings of incompetence or helplessness, feeling like a bad parent, that they have no control, even if they are not, particularly if they're not the perpetrators of the traumatic event. They also will develop learned helplessness if their reaction to the traumatic event and the behavior that results from it aren't addressed. So complex trauma, there's 6 areas of complex PTSD. We'll cover each of these real quickly. First is affect and impulse regulation. So their affect intensity, the emotional intensity, is easily triggered and slow to calm. Very, like a better term, very moody. They may engage in tension-reducing behaviors such as alcohol or drug abuse, self-injury, may be preoccupied with suicide, might be sexually preoccupied or hypersexual, and might take excessive risks. One of the reasons to point out these domains is these are clues when dealing with a student that's behaving in ways that are not pro-social and problematic in the school setting, and might be clues that there might be something underneath these behaviors. So in identifying what these behaviors are, we then these are clues that this might be something going on with this kid, that they might be suffering from PTSD or traumatic stress. Second domain is attention. So they may have memory loss or gaps, which is more common again with those that are repeated to chronic trauma or recurrent trauma, and disassociate. They may experience memory loss or gaps. They might dissociate, sometimes unbidden, where they just kind of check out for a period of time. Could be in class, could be anywhere. Self-perception, that their learned helplessness and feelings of guilt and responsibility and shame, and that nobody else can understand what they're going through, which again, for resolved trauma, can help them connect with others that are dealing with that particular issue as well. They might minimize something that was particularly traumatic, a single event perhaps, feelings of repeatedly saying, "I'm fine, it's not a problem, I could take it, not a big deal." Whenever I have a rule of thumb when it comes to kids saying "I'm fine" and nothing else, for me, fine stands for effed up, insecure, neurotic, and emotional. So saying "I'm fine" is often minimizing something that's actually going on. Relationships, inability to trust. they can they often use relationships to engage in reenactment, either re-victimizing themselves by reenacting the traumatic event or victimizing others. The reality is those that are victims of physical abuse or sexual abuse are far more likely to reenact that abuse by victimizing others. And the unfortunate reality is that those that are abused are are likely to victimize far more people. So our understanding of trauma as it continues to grow is that the victim pool is growing at an exponential rate. Recently saw a stat that a victim of sexual abuse, those that become perpetrators themselves, are likely to abuse anywhere from 20 to 50 victims themselves. So doing the math, it's quite staggering.
And ultimately, that victimization of others is an attempt to control the situation that they themselves couldn't control.
Correct. So those kids that wind up in the nurse's office frequently complaining of, in particular, abdominal pain is a pretty big one. That doctor's visits have been unable to pinpoint the source of, is a potential indicator of trauma. Again, digestive complaints, cardiopulmonary symptoms, rapid heartbeats, that fight or flight response triggered for no particular good reason, and again, sleep problems, trouble falling asleep and staying asleep is quite common. Meaning making, for those that in particular are exposed to violence or in their community, violence in their home environment, often see their future in a much foreshortened way. It's certainly in interacting with those that are perpetrators and victims of violence, such as gang members, their perceived life expectancy is much shorter than someone who's not dealt with a particular trauma. Their sense of justice and fairness is certainly skewed. That there's certainly no such thing as justice and certainly no such thing as fairness. As demonstrated by this comic, there's belief in a God, but believe in God simply because there's that learned helplessness that somebody's to go through such pain and stress and distress, that somebody's got to have it out for them. So how trauma can impact development in young children, school-age children, adolescents. The traumatic events can have a severely profound impact on the developing brain and the developing individual and developing personality, which can result in some very difficult issues to treat when they reach adulthood and their brain is done developing. If these aren't addressed earlier on in the process, can become lifelong problems and issues. So childhood traumatic grief, following the death of a loved one, when the child perceives the experience as traumatic. So, losing a parent as a result of violence or domestic violence, something of that nature can, certainly be perceived as traumatic. And when the trauma symptoms interfere with the child's ability to navigate the typical bereavement process where they get stuck, so to speak. In the different definitions: grief, intentional emotional distress following a death; bereavement, the state we are in after the death; mourning, the cultural or familiar or social rituals associated with bereavement; and traumatic grief can be grief associated with a traumatic death. So with traumatic grief, can have intrusive memories about the death, avoidance and numbing, increased physical or emotional arousal. All of these things sound very similar to what we covered with post-traumatic stress disorder. So complex childhood traumatic grief can often these symptoms can develop if you have a student that loses a parent, particularly suddenly or violently. These are some things to be on the lookout for in the development of potential traumatic grief. Reminders: person, places, situations that are that they associate or are reminiscent of the loss of that, anniversaries, birthdays, holidays. These are all things that can, loss reminders, that these are things that remind the child of the loss and can trigger these symptoms. So infants and young children evaluate threats to the integrity of their self based on the availability of a familiar protective caregiver. And recent research has determined that the threat to a caregiver is the strongest predictor of PTSD in children under 5. So for very young children, in getting, if there's a history available, and that you know that there is a loss of a parent or a caregiver in a particularly traumatic way, that there's a very high likelihood that they're going to experience complicated or complex grief. Some of the symptoms that we see with school-age children is the thoughts of revenge they cannot solve, self-blame or guilt fueled by magical thinking. If only I was able to tell my mom to stop sooner, and that truck would never hit the car. If only I didn't call. If only I did this. Only I did that. Feeling of guilt that they could have done something. If only they could have done something mystical or magical, they could have stopped it from happening. Sleep disturbances, fear of sleeping alone, impaired concentration. And here it's important to, we're I think far too quick to label a child as ADHD when it might be something else going on. It could very well be anxiety due to the complicated grief versus a attention deficit issue. Learning delays, physical complaints, developmental delays, and traumatic play. So reenacting that reenactment of the traumatic event through their play is a indicator that they might be experiencing traumatic stress. So adolescents may feel like they're going crazy, may be embarrassed, may isolate. They may have repetitive thoughts about death or dying, or revenge fantasies that they can act out and cause them to take risks. They may avoid or engage in social withdrawal. One, tension, reducing behavior, and we cover this more in depth in another webinar that's available for your perusal on the website. Self-injury, non-suicidal self-injury is what the technical term is for it. It's not suicidal in intent. The idea of self-injury is not to end one's life, but it's a way to cope with particularly strong emotional state, to regulate their emotions. In some ways it can be used some people utilize self-injury as a way to reduce particularly strong emotions, or to experience some sort of feeling when they have difficulty feeling anything at all. It's an effective coping skill temporarily, but of course that the risk to physical integrity doesn't make it a viable coping skill. One of the things particularly to be on the lookout for is self-injury can be contagious, socially speaking. If someone is experiencing complex trauma symptoms, traumatic stress, and is engaging in self-injury, they will often engage other students or other peers to engage in the behavior as well. Those that are not necessarily encouraging them, but will certainly share with their peers that this is something that they're trying out, which leads to experimentation with this behavior by other students. We're seeing this quite a bit in our middle schools. So if there's one kid that's being identified as self-injuring, it's a good idea to take a look at their social group and do a quick assessment of them as well, and assess for self-injurious behavior in that social cohort. So neurobiology and trauma. Early trauma, prolonged separation, insecure attachment produce permanent changes in the neurochemistry of children that continue into adulthood. They may have developed a neurobiological sensitivity to loss and have long-lasting issues with fear of abandonment, hyperarousal, and very sensitive to environmental threats, hypervigilant. Together, insecure attachment and early trauma produce extreme affective dysregulation with concomitant difficulty in modulating aggression in adults. What that means is these folks have difficulty dealing with particularly strong emotions and are prone to very significant mood swings, anger, and aggressive behaviors. Here's a scan, PET scan of two brains. One is a healthy brain. The one on the left is a healthy brain. The one on the right is the brain of someone who's been affected by trauma. As you can see, the neurological activity is markedly different. Towards the top there is where you have the good idea, bad idea, executive functioning of the brain, and as you can see, there's far less activity there than in a healthy brain. Childhood trauma occurs during sensitive neurodevelopmental periods. The brain is growing. It's developing connections and branches, and as they go into adolescence, pruning is going on, so these neurological connections can become hardwired, and the trauma can affect fundamental psychodevelopmental processes. It can have long-lasting impact if it's not addressed. Maltreated children have lower social competence, have less empathy for others, more likely to be insecurely attached to their parents, less able to recognize their own emotional states, and have difficulty in recognizing others' emotions. These become hardwired if the trauma is not addressed, and those skills are not learned in a therapeutic setting. So how do we know if it's trauma? Ultimately what it comes down to is utilizing that trauma lens that we talked about initially. Knowing this information now, if it looks like a duck and it's quacking and has feathers, chances are it's a duck. And to know what the limits are of your particular setting. Are you equipped to identify or diagnose a trauma? If the answer is no, if you suspect that might be part of the package that's presenting itself to you, then it's really in your best interest to refer that individual on to someone in the community that has a specialty in trauma. Not every therapist knows how to identify or assess or evaluate for trauma, and even fewer know how to actually effectively treat it. So you need to do a little homework in your home community as far as who are your effective trauma experts, and develop a relationship with them. So when these kids come across your doorstep and you need to get them assessed, that this might be part of the issue or might be the issue driving their behaviors, that you have someone that you can refer them to. Restrain the impulse to dig too deep into traumatic events. Once you start to unpackage trauma, it can complicate very quickly, and you may find yourself in some pretty hairy situations. The behaviors that are not necessarily pro-social that they engage in to cope with the trauma or the traumatic stress, when addressed and picked apart, or they're no longer able to engage in them, that can lead to re-experiencing of the traumatic event or traumatic stress to the point where they act out in even greater ways in a way to try to cope. So use caution is my best advice, and have developed some good relationships with folks that know what they're doing with complicated grief and trauma and PTSD, and get those kids connected. With that, I would ask if there are any questions, because we are right at 12 o'clock right now. And certainly if any questions come up after the fact, this is my email and email address and phone number. Feel free to shoot me an email or call me if any questions do come up.
I have opened the mic, so if there are any questions, feel free to ask them now. Hearing no questions, I am going to thank everyone for attending today. Thank you, Don, for a great presentation, and I appreciate everyone joining us today. Join us for additional webinars as they become available, and look for those via email, on our website, and through our Twitter. You can follow Prevention First at SA Center PF on Twitter. Also, if you are involved with the Student Assistance Program, you can join us on our new group site. If you would like to do that, you can email me, Dale Gasparovic. It's dale.gasparovic@prevention.org. We look forward to seeing you again at our future webinars. Thank you.